COVID files on, but if I put them there, so we have to move them when we have refreshment. If I keep them on here, oh yeah, because we're not using it.
Hello, good evening. Can everybody hear me?
Yes, sir.
Can you see me?
No.
No, no, sir.
Too many people's mics are not muted.
All right, can we go ahead?
Yes, we can go ahead.
All right, good afternoon, everybody. I don't know why you're not able to see me, but with all of what happened today,
And turn on your camera
was
now.
expected, yeah. So the camera was working a while ago. All right, but we're gonna go ahead. So good afternoon, I'm Dr. Manning. Welcome to this web-based roundtable discussion on COVID-19. COVID-19 is here, it is now here, and we are all faced with it, and we cannot hide from it. Simply put, it is, in my opinion, the greatest public health crisis faced by Jamaica, indeed faced by the world in modern times, certainly since the Spanish flu. A large part of the challenge, aside from the high mortality rate, including mortality among healthcare workers, is the epidemic of fear which has accompanied the virus. We must, as healthcare workers, keep calm in facing this challenge. It is not just a cliche to say this. Remember, fear will paralyze us. Fear will prevent us from taking much needed decisions and actions. We need a calm and logical response to get through this. Now, before we start, I would like to thank Professor Marvin Reid, President of the CCFP, for initiating this activity. Also, the Ministry of Health and Wellness for facilitating this roundtable, and of course, our roundtable members, Dr. Kathy Pate Robinson, Prof. Peter Figueroa, Dr. Karen Webster Carr, and of course, you, the audience. I hope I haven't left anybody out, and let's get started. There is an agenda here, and I believe we're now going to go to Dr. Kathy Pate Robinson to speak on my experience in caring for COVID-19 in Jamaica. Dr. Robinson, are you ready to go?
Good
Dr.
afternoon,
Robinson?
everyone. Can you see me, Dr. Manning?
Yes.
I can see you. What's
Afternoon, everybody. Oh, there you are, Dr. Manning. So, in regards to my experience, it's been a bit of a roller coaster ride. We have been in a mad rush to get ourselves together, to get our teams prepared, to get all the people in the hospital on board and ready, and a lot of preparation is still in progress, and every day is something new. We are learning each day as well, because we started off with a protocol that we had for the university hospital, and almost every day we make adjustments as new challenges come up, new issues come up. For example, right now We have concerns from other services outside of medicine that are now starting to see patients on their wards with viral upper respiratory tract symptoms, maybe long-standing admissions, maybe new admissions. And there is, as everybody I think knows, a lot of fear and to a great extent still a great deal of confusion as to how to proceed with managing patients, which means that sometimes people are overcautious, although there are those who don't take enough precautions for themselves. And I think the myths that are going around and some of the stories that are being spread are really hampering good practice, because every now and again, every day, multiple times a day, you're seeing new reports in the media, you're hearing new things, and I find that a lot of people are focusing on maybe one word that they're hearing. So for example, recently, we have heard a lot of talk, seen a lot about airborne transmission. And that has created a lot of challenges, partly from the perspective that everybody hears airborne transmission, ignores the context of the statements, and then we're not really certain what to do. So traditionally, coronaviruses are not considered for airborne spread because of how they operate. They're really talked about for droplet spread. But as we have found out with this particular pandemic, when you have procedures that can aerosolize smaller droplets, then those smaller droplets may remain suspended in that area for a prolonged period of time. And if you have recirculated air, then that may spread those smaller droplets, which may mimic airborne transmission in a particular zone of spread for a short period of time. How short varies on the size of the droplets, because droplets smaller than 10 micrometers can remain suspended for a prolonged period of time. And environmental factors play a role. So if you have an air circulation system, like a central air conditioning unit, then that may pick up these small droplets and spread them around. And if that recirculation system is not properly filtered, which in Jamaica we tend not to have, then it means that you may be recirculating these infectious droplets, which is why we are very cautious about things like the use of fans and AC units, especially central air conditioning units, when we're dealing with patients, which is why the social distancing is so important. Because if I cough or sneeze and my droplets can spread for 1 to 2 meters, then I really need to at least try to maintain that 3-foot distance. But people don't think about it until they're presented with it right in their face. And then staff are treating staff badly. Oh, you work on the COVID ward, you stay over there. You're not to come and walk in the hospital car. The nurses complain all the time, and they're experiencing a lot of discrimination. And sometimes I have to say, boy, you know, now you're feeling what my HIV patients feel every day, because they are scorned and discriminated against, and people may even get violent. And we've even had cases of doctors, for example, reports at least, that there may be doctors spraying patients with Lysol, and Lysol is a harsh chemical, mix of chemicals that should not be applied to the skin. It's for surfaces only, and it's not for every kind of surface. So a lot of these fears in ourselves, in each other, in other people, have created a great deal of challenge for the provision of good health care, and the quality of care goes down. We have had challenges just cleaning the hospital because the cleaning staff were so afraid that many didn't turn up when they heard that the university hospital was the COVID hospital for Jamaica. So it's been a very challenging roller coaster ride for the past 2 to 3 weeks. And we have multiple meetings every day like this, online meetings for the most part, thankfully. but it's a hard thing to balance preparation, fielding the phone calls, seeing the patients, and helping to calm everybody else. And then we have to stay calm too. I mean, I have concerns for myself and for my family. It's not that anybody who is on the front line and dealing with things is not also concerned and under a great deal of stress. Sometimes we don't sleep, sometimes we don't eat, but we have to keep going. I don't know if that's what everybody wanted to know, but I think that's, you know, a part of my perspective.
Thank you. Andrew?
Yeah, thank you.
I appreciate
Kathy.
that.
All right, we're going to go straight into the next segment, which is the rationale underpinning public health response, contact tracing and testing philosophy. And that's from Peter Figueroa
Yes, sir.
or Karen Webster.
Yes.
So, everyone might be so.
Minister of Health,
It's up.
Sir
Okay,
Peter.
Dr. Andrew and Marvin and colleagues all. Are you seeing my presentation? Okay, it's up. So the name of my presentation is to try and empower ourselves so that we can better control the epidemic. Next. Next slide. I'm controlling it? No, I'm not. Oh, Marvin, are you controlling my slides? Yeah, but you can control your slides. Just share your screen and control your slides. Okay, thank you. So this is update. I have gone through the World Health Organization Joint China Mission report. They've now reported, I've gone through that report and use this to update what I'm presenting. Now, Andrew mentioned that this epidemic is a huge challenge. But you know, if you look at my slide there, you can see that we've been through challenge after challenge in the past 40 years. I was first in public health when we had the parathyroid poisoning outbreak in 1976, and all flour had to be withdrawn from all shops in Jamaica for about 3 weeks or longer. And let us not forget that 35 years ago, we went through an equally challenging situation with the early cases of HIV, when we had absolutely no treatment for people who were dying. And throughout the 1980s, we had no treatment. And for us into the 1990s. So we've dealt with things like this. And as Andrew said, the calmer we remain, the better we are able to deliver with it. We now have over 300,000 cases reported. China, it is worth noticing that the WHO report said that their response was unique and unprecedented. And that is why over the past week now, their numbers have hardly budged, but they still have over 50,000 people in treatment although the number of new cases have reduced drastically, because you cannot release anyone from treatment until they have 2 negative PCR tests. We know what's going on in Italy. United States is exploding. The earlier cases seem to be more severe, and we are less experienced with dealing with them. And therefore, in China, you will see that in January, the death rate was considerably higher than what it was in February. Next. Now, we're still learning, as Kathy said, but it's primarily person-to-person spread from persons who are symptomatic. Asymptomatic infection has been reported, but it is rare. And many of the persons who are said to be asymptomatic and spreading, they are in the early stages of symptoms development. But also the touching of contaminated surfaces.
Jay, I know video chat phone. Let me call you back in a second. Yeah? Yeah? Can I call you back?
Prof, before you start again, could I ask members of the audience to just mute their microphone? Any little thing that you say will interrupt the presentation. So just press mute until you want to ask a question after the presentations, please.
Yeah, thanks for that. So if we touch contaminated surfaces, then the question of touching our face, mouth, or eyes can cause infection. Next. You're all susceptible. Cases among children are rare. They do occur, but they're rare. Young adults rarely ill. Most persons will recover. Some persons remain infected even after they recover. One patient up to 7 days. So this is why we have the 2 negative tests prior to discharge. The elderly, especially those with comorbid condition, are the ones most at risk, as well as, of course, health providers are at risk and must take special precautions. Next. Now, looking at the WHO report, you'll see that fever, perhaps 88% of cases. This is data from over 55,000 cases in China, especially in the elderly. Sometimes the elderly do not show fever. Fever, cough, 68%, fatigue, 38%, sputum production, 33%, shortness of breath, 19%, myalgia and or arthralgia, 15%, sore throat, 14%, chills, 11%. Things like nausea and vomiting, nasal congestion, only 5%, diarrhea, 4%, hemoptysis, 1%. So we need to bear this in mind, particularly when we are seeing persons in primary care. Next slide, please. Again, taking it from the WHO report, 80% of cases are mild or moderate. Now, a moderate case may have pneumonia, but usually not severe pneumonia. 14% of cases are severe, where they'll have dyspnea, they'll have an accelerated respiratory rate, 30 or more breaths per minute, and oxygen saturation may drop below 93%. So these are the persons who need to be in treatment in the hospital. Critical cases, 6%, in which there's respiratory failure, septic shock, or organ failure. it is those who are over 80 years of age who have the highest case fatality rate of 22%. So case fatality increases with age. Next. I'm going to share these slides with everybody afterwards. Clinical course of COVID-19. The incubation period is usually 5 to 6 days after infection, therefore after exposure. But it can go anywhere between 1 to 14 days. Persons may have symptoms for about 7 days. It's around that period, 5, 7, 9 days, where some persons deteriorate rapidly and need to be put into hospital and highly supportive care. Next. Now I'm just going to remind us of the measures to prevent spread. Hygiene. We really have to reminding each other. Cleaning of surfaces in our offices at least 2-3 times a day. Suspending events with crowds. Now we are talking about social distancing, but a better terminology is physical distancing.
Hello.
We want to make
all right.
action.
My name is Sean Carey, Mr. President. Sorry to bother you at this hour of the day, but I heard you were there this morning.
Yes, I saw her.
Dr. Lurin, can you mute your microphone, please?
Peter, can you unmute your mic again for me, please? I just muted all. Peter, can you unmute your mic?
Yes, we've done it. Are you hearing me, Marvin?
Yes, go ahead, go ahead.
Thank you. Okay, so I was saying that we should talk of physical distancing because, especially for people who are quarantining at home or wherever, they need the social contacts to keep up their spirits. So you have to promote social contact online but keep physical distance. Minimum of 1 meter, but in fact 2 meters better where possible. Intensive contact tracing, quarantine, isolation, aggressive testing, and I'm going to say a little more about that. Now GPs are to refer persons who need a test. They have to refer for testing. We're not asking a GP to do the test themselves at this point. And of course, health providers must have personal protection equipment. At a certain point, you have to consider total lockdown. This is what made the difference in Wuhan. And you can't wait until you're being overwhelmed. Sometimes you have to lock in advance of what is coming in order to be really effective. Next. Now, in terms of testing, we're already saying all suspected cases of COVID-19 need to be tested. All patients with pneumonia and severe acute respiratory infection, persons with fever, cough, or symptoms suggestive of COVID in areas where there have been COVID cases. We need to look at testing in these situations. Right now, community, at least one community, they're doing door-to-door surveys, testing fever, asking about symptoms. These people need to be tested if they meet this definition. Frontline health providers, caring for if they develop fever, cough, or suggested symptoms, need to be tested. And I think we need to do some quick surveys of some patients, not all, some with influenza-like illness, in order to get a feeling as to whether community spread is taking place and we are not recognizing it. Again, testing of asymptomatic persons is not productive. Remember, even with someone who is symptomatic, if you're using the PCR test, it is unlikely to become positive in under 3 to 5 days. So sometimes you test someone with symptoms, it's negative, you may have to test them again. Public education. Don't spend too much time on it. Someone has muted their mic, please. Have them put their phone on vibration. Remember, practitioners are so critical in getting the correct information out. So you need to be proactively alerting all your patients of the appropriate information, the hygiene, etc. Let's go to the next one. If you have symptoms of a cold and fever and have not traveled or been exposed to a suspected case and not been within a community that has been identified with transmission within the past 14 days, it is still unlikely that you have COVID. So you stay at home until you're better. You can take home remedies, get a family member to get you over-the-counter products so that you don't go to the pharmacy. There's no need to see a doctor. It's only if you develop shortness of breath, difficulty breathing, or severe symptoms and you encourage your patients to phone you before coming to you so you can guide them. Most persons with COVID will recover. Next. Quickly on preparing the GP's office, you have to brief and educate your staff and remind them, review your procedures, ensure basic supplies, keep the guidelines handy. Remember the guidelines, it's dynamic, they change. Ensure you have the key telephone numbers readily available, not only to you, but to your receptionist, your nurse. Discuss with the staff how you will manage different scenarios. Identify how best to manage and isolate patients with acute respiratory infection. Try and advise and manage some patients by phone, but I really do think that primary care physicians, where possible, need to stay open for those patients with conditions that need attention. Many of them need new prescriptions, diabetic patients, patients with HIV, a whole range. So you can accelerate many patients through your practice, but some really do need to see you. I suggest that you get your receptionist to welcome your patient, but ask them to sanitize immediately. And have the sanitizer available for those who do not have tissues available. Encourage your patients to phone ahead. If someone comes in with a cough, give them a mask immediately and then isolate them to one side. Try and deal with them immediately, but keep reminding your patients that children and adults will usually be fine. It's the elderly who will be at risk. And then make sure that you keep cleaning the surfaces, the door handles, the switches, the desk, the chairs. Wipe and clean the surfaces several times a day. You can use bleach diluted, or you can use disinfectant. Next. Case definitions: persons with acute respiratory illness, that's fever and at least one other sign, no other etiology, a history of travel or residence in a country or area that is affected in the 14 days prior to symptoms. Next. A person with acute respiratory illness who has clearly been in contact with a confirmed or probable case in the past 14 days. Or a person with severe acute respiratory infection who requires hospitalization and no other etiology is established. And these cases all need a test quickly. Of course, confirmed cases, those who test positive. Thank you.
Thank you, Prof. Thank you, Prof. Figueroa. You can now see me. I'm speaking from the emergency MAJ studio somewhere in central Jamaica.
All right.
It's my office. Now we're going to go straight to the next speaker, who I think is Dr. Michelle Roof. Is that correct? Prof. Reid had sent out a questionnaire. I know there are a lot of questions, but we're going to take them after the speakers.
Dr. Manning, I would go next.
Okay, and you're speaking on what?
The contact tracing.
Sorry, what are you speaking on?
Contact tracing.
Contact testing. Okay, so I stand corrected. So Dr. Karen Webster-Carr will be speaking on contact testing. You have the mic, Dr. Carr.
Okay. So we're trying, but I need to, where's the share? Oh, I'm going to share, I'm just going to do it from my, so are you seeing mine?
Yes.
Okay, great. So we all know what contact tracing is. We're really trying to find persons who may have been in contact with somebody with a virus such as we have with SARS-CoV, as they are at high risk of becoming infected and potentially infecting others. And there are really 3 steps: contact identification, contact listing, and then finding these persons and following them up. The action out of this may result in quarantine or isolation if persons are symptomatic. So Prof. Figaro already gave you these case definitions. So the types of contacts as given by WHO for COVID-19, you take a contact with a person that you may have been exposure maybe 2 days before up to 14 days after onset of symptoms. And they have defined the different categories as face-to-face contact with a probable or confirmed case within 1 meter and for more than 15 minutes. So this is new, we now have a time. And then there's direct physical contact with a probable or confirmed case, or direct care for a patient with a probable or confirmed COVID-19 disease without using proper personal protective equipment or other situation that may be different for Jamaica or particular for Jamaica. So we're looking at the Jamaican experience now. We have 19 cases, 13 of which are imported, and 5 have been with local transmission from an imported case. And then there is 1 with weak contact history with an imported case. And so we'll describe them a little bit. So the first chain, so with each person, new person starts their own chain. So the first chain we know is the Bull Bay case, and that has generated 5 other persons. These are all single contacts. Number 3 is a group of persons from the UK, 3 persons, or mother and children, 2 children, adult children, who came from the UK, and they became symptomatic on different days. So these are imported cases, and they became symptomatic while here. The number 4 chain is a case or 2 persons who traveled together from Malaysia to Dubai to Trinidad and then on to Jamaica, and they became symptomatic on different days. So if we look at the source of infection, we have 5 imported cases from United Kingdom and 5 import-related cases. The USA had 4. We had 4 imported cases from USA and 2 from Malaysia, Dubai, Trinidad, and then 1 that came back from Trinidad. There was a crew member who
is a conference with GPs in Jamaica.
With,
and they have all the top people in the ministry giving them all the data.
Portugal, Miami, and then the one with a weak contact. So I'll tell you a little bit more about that. This is the geographic spread of cases. So the clusters may seem far apart on the expanded one, but they are really on top of each other, but we moved the points so that we could show that there are more than one case. So this is related to the chains of transmission that were seen in the 2 slides previous. So we talk about contact tracing. So this is what our contact tracing looks like. So we have interacted with a number of persons, over 600 persons, and gotten their as contact to our cases. And this is the spread across Jamaica. So we are following persons in different parishes related to the contact tracing. So we spoke about the one person who had a weak exposure history. They shared, they traveled on the same taxi around the same time, but they were never in the taxi together. And they live in the same community as the confirmed case. So for us, that is not strong enough. And so we want to see if there are other possibility of community spread. And this is so we are doing surveillance using SARI Sentinel sites that anybody who we would have picked up in our usual Sentinel site for influenza, we are also testing them for COVID, whether they fit the case definition or not. We are also doing contact tracing and house-to-house visit in the area. And anybody who is symptomatic or have an influenza-like illness will be tested. For the nearest health center and the nearest hospital, samples will be done for influenza-like illness as well as persons with severe acute respiratory infection, or they have been admitted for a lower respiratory tract infection or pneumonia. So we are also, somebody has their mic open. Could you mute it, please? And the next step we are looking at is testing of SARI and admitted LRTI at our hospitals that have active surveillance, which include both public and private. So that it seemed to be our next step. So just to give you some data on what we are seeing. So the blue line looks at the Port Antonio Health Center, and we're not seeing any change in the influenza-like illness for all age groups in the Port Antonio Health Center. At the Port Antonio Hospital, we really haven't seen anything that looks alarming there. And just to share what's happening in Jamaica, this is our severe acute respiratory surveillance. Right now, we are not seeing a lot of SARI cases or more than what. So this green line represents the seasonal threshold. And so we are even below what we usually see for influenza. So there's nothing there, but we have tested a number of these and they're all negative so far with respect to SARI surveillance for COVID. This is what our admitted lower respiratory tract infection looks like. So we are within what we would expect for the season, and there's nothing happening strange there at this time. But this comes in a week after, you know, so this is historic, in a sense, historical now. So on Tuesday evening, we should have the update for the next week. Just to say, so for Jamaica, or this is the classification or categories for transmission patterns that the WHO has just introduced. Initially, there was just imported cases only and local transmission. Now they have 4 categories. Somewhere that had no cases, then sporadic, which is imported or locally detected, 1 or more cases, cluster of cases, countries, areas experience cases clustered in time, geographical location, and or by common exposure. And then the final category is community transmission, where there are larger outbreaks of local transmission, and there are a large number of cases not linkable to transmission chains. So we're not sure how we're going to be classified, but I figure we're either between sporadic cases or clusters of cases, but we're certainly not at community transmission at this time, at 3:44 p.m. on the 22nd of March. That things change so quickly. So that is what I would like to share with you just now. So thank you very much.
Thank you, Dr. Webster Carr. Now, we have 2 more speakers, I think. Are we going to go with the results of the questionnaire now? I didn't hear that.
So Andrew, I'll just do my presentation, and then Michelle will then do her last bit on digital health, and then we'll open the floor for the discussions.
All right, so Prof.
In the interim, if anyone has any burning question that they think they may forget, they can put it in the chat.
All right, go ahead, Prof.
All right, hopefully you'll be seeing my screen, which has preliminary results on COVID questionnaire. So briefly, in organizing this meeting, we wanted to get a feel for what were some of the concerns that primary care physicians or healthcare workers in general were experiencing as they cared for their patients or their constituents during the course of the week. Considering that we're now in the phase where every day we get reports of increasing rise in the number of cases. And so I developed this questionnaire on Friday evening and disseminated it yesterday with a cutoff point of 10 a.m. today for analysis. So essentially this just represents the first parts of the report. So essentially we had 56 respondents, most of whom were females, 43 females and 13 males. But the age distribution was relatively uniform. We had some doctors, roughly about a third of them, who classified themselves as 60 and above. And we did have some of the younger doctors, but that comprised a smaller proportion of the sample, less than 6%. In terms of professional category, because the questionnaire was open to, although targeted to primary care physicians or to physicians in general, it was really open. Anyone with a link could answer the question. And we saw that there was about an even split of individuals that worked both in the private sector and in the public sector. So the vast majority of individuals worked exclusively in the private sector, and about a similar amount in public and private. And the public sector came up third at 12%, sorry, 7 out of the 56. So we did that. Right, so in terms of knowledge, just to say that the vast majority of respondents were physicians, and there were some specialist physicians as well, which was the second ranked category. In terms of the case definition, we found that most people reported, almost 100%, that they were aware of the case definition of a suspected case of COVID-19, so this was reassuring. And the question was, in the past week, have you referred a suspected case to the public health authorities? And the idea here was whether or not you may have become aware through the course of your work of somebody who may have been a suspected case, and did you call through or assist them in calling through to the public health authorities? The numbers reporting the answer yes for that was roughly just 9 out of the 56, which is less than 20%. But for those who reported that they had to assist their clients in interfacing with the public health, the average rating that they gave the public health response was really 2.5 out of 5, suggesting that individuals were not very pleased with the response from the public health team. And some of the reasons given was that really seemed to be communication issues. Either the patient was promised a call back and that didn't happen. There was some delay in the response of the public health team. The fact that the doctor and the patient and the public health system weren't happy with the response, in the sense that they were unhappy with how the ministry was defining a case and refusing to test. So those were some of the comments that were offered as to why is it that the average response was rated at the level that it was given. In terms of seeing an individuals within your office or suspected individuals within your office, and so I define that as a professional encounter or to be near to anyone who may have had COVID, only about 7 of the respondents responded yes. And when we asked, how would you rate your own confidence in dealing with a suspected case of COVID, the vast majority of persons felt reasonably confident that they knew what to do in dealing with the patient. So for those who gave positive comments, their positivity, to use the term, was because they felt that they were following the guidelines as issued by the Ministry of Health. They were confident in terms of the preparations that they themselves had met, and that those individuals, some individuals reported that once they had the proper PPE, personal protective equipment, then they were confident they had no real fears. However, those who gave some negative comments said that although it is that they were trained in the use of PPE, because they haven't practiced it much, they were not very confident. They weren't confident in the facility that they were working in, whether the facility was adequately prepared. They weren't confident enough about protective measures. Some were not confident about their own individual knowledge. But another point that came out is really the transmission. Some individuals were concerned that the primary method as described, or transmission as described, may not be the full story. And so they were concerned as to whether or not they may be unwittingly be exposed to the virus. And of course, there were some concerns about the adequacy in terms of numbers and access to personal protective equipment. When it comes to whether or not they received any amount of training on the COVID response, it was roughly about 50-50, in the sense that roughly half of the respondents, a little bit more than half of the respondents, reported that within the past month, they received some training on COVID-19 infection. And here is where the professional associations and the local health authority were the predominant trainers. The university states came up third. And some individuals have even reported that they have done some of the online training with WHO, PAHO, and CDC. In terms of information source on COVID-19, the vast majority of individuals reported that the Ministry of Health is one of their primary source. And I think the ministry needs to take this responsibility, which I know they are, quite seriously, because this is where a lot of the doctors and healthcare providers say they're getting their sources from. The next ranked source is really internet sites such as Medscape, CDC, and PAHO. And general internet sites came in at third. So the pivotal question really was whether as a healthcare provider, were you considering withdrawing your service from the community? And here we have really, if you add your yes and you're not, if you had your yes and not sure, you're getting roughly about 30 of the 56 individuals, a slight majority, about 55% of individuals who says that they're really considering or giving some thought to withdrawing their service from the community. And this from an organizational standpoint, so from where we sit at the Caribbean College of Family Physicians, is something of some concern. And I think the ministry will also be of some concern for this particular response. And when we asked what could be some of the possible reasons for considering withdrawal, the vast majority of individuals came back to say that they were concerned for their family and their employees, that they may become the source of infections for their family and their employees. Some individuals have reported that their concern relates to the adequacy of the required PPEs, as well as the fact that they themselves may be sick in terms of having some comorbid issues. When we look at a few questions that were designed to assess attitude, we found that the majority of individuals reported that they have implemented a triaging system which they deem to be effective. But the vast majority of individuals either reported feeling anxious or fearful to interview an individual within their office with COVID-19. And only a small minority, less than about 30% of individuals, felt comfortably enough to interview a patient who suspected COVID-19 in their office. So to summarize, this preliminary report really says that the respondents had a reasonable distribution across age and work setting, with a female preponderance in terms of their respondents. The public health response to referred cases of COVID-19 received an average rating. Most respondents have not encountered a suspected case, and that's really is corroborating some of the data that Dr. Webster-Carr shared with us in terms of the spread. The majority of the respondents are aware of the case definition or operational definition that we're using. There clearly is a gap. There's clearly some need for additional training and more training, and events such as these, I think, will go a long way to resolving some of that training deficit. Of concern is roughly about half of the respondents are considering withdrawing their service out of concern primarily for their families and employees. And there's still quite a bit of apprehension and anxiety in dealing with COVID-19 in office. And this is common irrespective of whether or not they've reported that they have an adequate triage system. So I think the data from this, although relatively small samples, 56, we have 426 persons on the call, most of whom I'm assuming are physicians. I still think it provides us with enough data to make some interventions. Thank you, Andrew.
All right, thank you, Prof. Reid. All right, we're going to go quickly into the last speaker and then have some questions and the panel discussion. So Dr. Roof is going to speak on digital health technologies in COVID-19. Michelle? Is Dr. Roof here?
She's there. She's setting up.
So while she's setting up, I think what happened earlier today with the whole technology thing illustrated a couple of things. One, we're here spread throughout the length and breadth of Jamaica, and at this difficult time, we're able to meet as a group and discuss this important matter. But it also points out that there are other things that need to be cleared up in terms of the technicalities of this communications apparatus. And Ministry of Health needs to get things sorted out, because we have a window now, couple of weeks before I think things will probably change in terms of the numbers of cases, and we'll have to be in quick and reliable communication. Dr. Roof?
Good afternoon again, everybody. So I just wanted to go through a couple of slides on digital health and COVID-19. So there are 3 proposed technologies that I'd like to share about. The first one is a platform for, an electronic platform for collecting data on cases and contacts and being able to link the two, being able to visualize the chain of transmission. It works on both mobile devices and desktops, all the different platforms. There's an offline mode here in the field. It's called go.data, and it's coming out of WHO and some partners. It was used successfully with the Ebola outbreak a couple of years ago, and it's been already configured for COVID-19. There was a online demonstration of this last week, Wednesday, for the countries of the Caribbean, and we had our PS sign off to say that we would be interested in moving on with this. It captures also hospitalizations and lab test data. We're outsourcing this, and we're expecting to have this up in probably a week from the time of the availability of installation files. WHO has indicated that they're doing some updates on this. The idea would be to have this in use in the field, which is where the data comes from in the first place. And when we have that going nicely, the reports are working, chain of transmission, etc., we would like to extend this to university and also to private sector. If you're seeing a case and you want to notify it, then you can actually just use the app in Android, iOS, your tablet, Chromebook, whatever. It's compatible with all of these. Just thought I'd show a few screens coming from the Android app. So as you can probably see, you can actually see for each contact, the person they were exposed to the index case, and then there's some details on them. We actually are working also with the NERGIST, which is a National Emergency Response Geographic Information System team at ODPEM. They're part of the National EOC set up because of COVID-19. We met with them last Thursday and Friday, and they have a wealth of skills there to help us to make a dashboard for Jamaica, to keep us, the minister, the executive, and us in the EOC and elsewhere aware of the georeference cases and contacts. And it will be near real time, not 100% real time, but will be near real time. We'll be able to also look carefully and agree on one source of truth for how many patients are in isolation at the different sites that we're using. So you can just see some of the screens for the patients, some of the details. As I said, we would georeference the locations and the symptoms and signs and so on. So as soon as we get this up and running, a week or so, we will report back to you, and we'll also be able to have some of you sign up for this application with the right access permissions. The next one is WhatsApp Coronavirus Information Hub. This was shared with me by a colleague from the IDB project. It's making use of WhatsApp without any patient information, and gives guidance for health workers, community persons, government persons, etc., the general population. It will be updated with the latest resources of the country, and we'll be able to use that as a source of truth at your fingertips. The cell phone is always in our hand. We're always on WhatsApp, and be able to kind of stay away a bit from the fake news. So this is an initiative of WHO, UNICEF, and UNDP partnering with WhatsApp. And it's been used in a few countries already, Singapore, South Africa, Israel, and a few others. So you actually can access this from the WHO website. You will see this in a lower right corner or something. If you click on that, you'll end up being in WhatsApp. Not now, we would set this up for Jamaica. We need to collaborate with PAHO to get us in on this. But there will be a Jamaican number at the top instead of the 41 number there. So you'll be able to put that number in, and it's once you click, it said it already has a starting message, which is hi. You click send, and it actually shows you on your screen, welcome to Jamaica, whatever it is. And there's a menu, news, regulations, myths, whatnot. So you click on, you don't click on them, you type in the word for what you want, and you get the updated answers. So this would be a quick way to share information rather than, even quicker than going to the ministry's website or something. And it would be our responsibility to keep updating the contents behind. The third and the last one, having some discussions over the last few weeks with Dr. Nadine Williams with IT and with our collaborator in the IDB project. How can we use telehealth for COVID-19? And looking at the survey results that Marvin presented a few minutes ago, one of the questions is in private and public sectors, what are some of the use cases or scenarios for using telehealth? What are some of the criteria? Bearing in mind that after COVID, if we're still alive, then this may become the new normal in terms of using technology, remote care. So we could probably even start with Zoom. For us, it would mean buying a few more licenses and being able to, determining the criteria, have some sessions with patients this way. And then there are other technologies which would take some more time to identify and to set up for us. Of course, with Zoom, we wouldn't be storing patient data on the server in the cloud of Zoom. That would have to be collected differently, but at least speaking with a medical professional, health professional, people can be assured whether it's something related to COVID or people who have limited access because we're reducing the crowds and looking at social distancing. And then last slide here is, again, just looking at some of the possibilities related to COVID on the left, related to normal patient life on the right. Prescriptions management would be something. I hear some pharmacies had some long lines. How would we be able to manage prescriptions in an electronic way without seeing the patient? Of course, there'll be limitations. You can't examine the patient, etc. So we'd have to really decide what are the criteria for using this kind of modality now. All right, thank you. Those are just some of my thoughts.
Thank you. No, very interesting presentation. So we're going to open the floor for questions. But before we do, Marvin, can you hear me? Marvin?
Yes, I'm hearing you. Go ahead.
Do the attendees have the ability to raise hands? I'm not seeing that option.
Yes, they do. Everybody has the ability to raise their hands.
How do you do that?
There should be
open the participant window, and it's at the bottom of the participant list.
Yeah, there are options at the bottom of the screen.
All right, good. So everybody heard that. So if people want to, we can't all shout at once. So if you want to ask a question, raise your hands. All right, so I'm seeing EOC Zoom. EOC Zoom, you have a question? EOC Zoom. All right, Francis Berry, Dr. Francis Berry, you have a question?
Yes, I'm here. Can you hear me?
Yes.
So I was wondering, if we look at the evolution of the disease, in particular, the rate of spread in other countries where the disease has had a significant impact, like China, Italy, Iran, UK, and now USA. And we compare it to what is happening in Jamaica. Would you say that we're following the same pattern? And if we're not, Why do you think that is?
I guess that's addressed to the panel.
Yes, that's addressed to the panel.
A little early to tell because what we have right now is the imported cases, import-related cases. And so we haven't really seen communities spread yet. And so what will happen when it starts to spread in the community, I think where you're going. So far, it seems, and we are investigating that, it seems that if there's community spread, it is not yet obvious. Obviously, things happen, persons come in, it's spreading, but it's at probably at a very low level, and we are not able to find it yet. Although we are trying as best as we can through surveillance methods for influenza to try and find it. So far, we have had 36 negative tests this week using that methodology.
I'm sorry. 1 second. After we've asked a question, please unraise your hand so that I can go down the queue. The next person who had a hand up is Monica Asnani. And while you're going, before you start asking, let me welcome Dr. Tufton to the forum. Hi, Dr. Tufton. Greetings. Dr. Asnani, please go ahead. You have to unmute your mic, yeah.
Hi, thanks so much, Andrew. Good afternoon, everyone. I want to just start quickly by really thanking CCFP, Marvin, Andrew, MAJ, and MOHW for all the fabulous work, especially in engaging the GPs. I'm going to put what Francis said in a little bit of a different spin, in that I think I'm correct in imagining or thinking, hoping it won't reach there, but planning nonetheless for that we are at the incline of our spread right now. We haven't peaked yet, and we should plan ahead for maybe a couple of months. So 2 quick comments, suggestions, and questions. Michelle Roof spoke to this, but I wanted to ask, does MOHW have any plans to utilize telemedicine? My issue is not management of COVID-19, which is, of course, is the topical issue, and we're all doing a huge amount of work on that. But at the same time, continue to manage the other beast that affects the Caribbean, which is the NCDs, to continue to provide management to those people and limit movement of people for healthcare. So I'm glad that there's some starting thought to this. A lot of GPs have been thinking through this. I would love to know that the MOHW is putting some plans in action. The second question is a little bit more recent, and that is, does MOH have, or can we plan to have some kind of a position on the use of hydroxychloroquine? Thank you.
All right, panelists, can we respond to that question?
We'll take first. And yes, Dr. Manning, Dr. Nini will tell you about hydroxychloroquine. And so it's on our consideration, and she will tell you a little bit more.
All right, can we go to Renee Badro, please? Monica, please unraise your hand. Renee Badro.
Hi, good afternoon. I'm Renee Badro. So we spoke about Dr. Kate Robinson and Dr. Figueroa, I believe, spoke about how the droplets are transmitted. But we know that sneezing causes a drop nuclei size of 0.5 to 12 micrometers in size. So how then can we not say that corona may be transmitted airborne through AC ventilation units?
Yes, panelists?
I think I I missed a part of that question because of the noise that was coming from somebody else's phone. Can you?
Oh, okay.
Go ahead, please.
Right. What I was saying is that sneezing can produce droplet nuclei sizes of like 0.5 micrometers to 12 micrometers in size. So how can we say that it is not possibly transmitted by airborne transmission? I'm not saying in terms of an openly ventilated place, I'm more talking in terms of AC.
You heard, Kathy? You have anything to?
I heard. I think we have to kind of go back to the data that we do have. Could I ask that the person who's labeled as bent, please mute their mic? So when you look at a lot of the data that exists for sneezing, coughing, and so on, for the most part, the droplets that are generated are large. Not that they cannot be generated in a smaller size, but the average size of droplets is going to be large, and the vast majority are going to fall within short order. It's impossible to say that you won't have small droplets, but that's going to be a relatively smaller proportion. If everybody was to follow proper cough etiquette and sneezing etiquette and, cover maybe, with tissue or whatever, hand towels, and discard and sanitize, we would really limit a lot of that. And ideally, if you're going to be in a zone where there is recirculated, unfiltered air, if you're sick, you should stay home, or you should work from home, or maybe rotate to another area. Because in general, I know all of us as healthcare workers tend to be geared towards taking care of other people, but we ought not to put our patients and coworkers at risk unnecessarily.
Okay, I do appreciate that, but I'm talking with regards to a patient that randomly walks in, because we still have patients randomly walking in to the A&E departments of different major hospitals and not being alert. The doctors, they're not being alerted ahead of time. So is there like a workplace procedure or workplace protocol that we want to open the ventilation system, if possible, for A&E departments?
Okay, Professor Figueroa would like.
SARS-CoV-2 is a relatively new virus. It's a cousin for MERS corona, and there's a possibility that this thing can be aerosolized.
Prof. Figueroa, you're going to say something to that?
Yeah, thank you. I've had the opportunity to go through the WHO report that has analyzed the epidemic in China. And they have been clear that the transmission is primarily from person to person, arising from persons with symptoms. If someone sneezes on you, then you're going to get exposed. But the question of the aerosolized question is primarily in relation to certain medical procedures like intubation in a particular area. So if you look at it from the epidemiological perspective, we need to focus on the main modes.
It must say review the WHO someone in
Tamara, can you mute your microphone, please? Tamara Henry.
The main modes of transmission is person to person. Not only have they found, but when they analyze it carefully, they find that the transmission is primarily through families and households. 80% of the transmission can be tracked through families and households. So of those health providers who became infected, many of them actually got infected through a household contact and not through patient care. So if you look at it epidemiologically, we must focus on the primary mode of transmission.
Okay, thank you, Dr.
Thank you,
Figueroa.
Prof.
I understand from
We're going to go on to the
epidemiological.
next person, all right? There are a lot of people waiting. So thank you, but we're going to go on to Dunclear Brown. Dunclear.
All right. Hello, everybody.
Doctor, why is it that my hand goes up from before Marvin, but you started with everybody else after Marvin?
I have a certain order in front of me.
Okay.
Bear with me. I'm dealing with the realities of the internet that we have. So Dunclear, go ahead.
All right. Hello, everybody. I have a quick question. Well, it's a 3-part, so I'll be very quick. So first of all, in relation to the mandatory self-quarantine that was imposed, how enforceable is it really? Because at some point the borders will have to be opened again. But from what I've been hearing from persons coming in is that there are no real checks that are in place to ensure that they do self-quarantine. And I have had persons who are telling me they had relatives that come in who are still up and down and they can't get them to stay at home. So how do we deal with that? Secondly, I saw a release from the ministry saying that random sampling of the healthcare workers is something that they're considering. So I just want some more information on that. And lastly, I saw that some Cuban professionals were invited here, and I just wanted some clarification as to how they'll be utilized in our fight against this.
Can anybody respond to those 3 questions? All right, Doc, we'll perhaps get back to an answer. They will formulate it. So we're going to recognize now Suzanne.
Hello. Hi.
Suzanne? Who is this?
Hi, this is Dr. Bisesa McKenzie.
Okay, the CMO. Go ahead, please.
Yes, I would like to just respond to those questions. In terms of the self-quarantine and the responsibility, whose responsibility it is to monitor persons, I think this is a time where we have to understand that everybody really have to become a Ministry of Health officer, because everybody in the population really has to start taking some responsibility in preventing the spread and transmission of the disease, because it is going to be impossible for the Ministry of Health and Wellness workers to monitor everybody. As time goes by and more persons become discovered to be positive, and of course their contacts will have to be traced, the public health team is going to be under a lot of severe stress to keep up with the amount of work that is to be done. So I think that we have to look at increasing our messages to say that every individual really has to be responsible, not just for themselves, but for their family members and for the persons around them. I think that is the only way that we are going to win this battle, if everybody takes on the responsibility. The other thing in terms of the sampling of healthcare workers, at the present time, what we are doing is that we are sampling healthcare workers who have influenza-like illnesses. So if you have contact or not with somebody who has COVID and you have symptoms of fever and respiratory symptoms, then you are to report it and we will sample the healthcare worker. And this is in order to give us an idea of what is happening. It is a part of a random sampling that is done, but yes, it is going to be on healthcare workers to say that anybody who works in a healthcare facility or who is seeing patients who have developed, if the healthcare worker has developed fever and respiratory symptoms, then we will sample them. In terms of the Cuban professionals, we are still at this time working on the deployment of those persons. However, we have identified areas where there is requirement for strengthening, and these persons will be deployed based on the needs of the regions.
Thank you, CMO. Thank you. Dr. Minota Scott, you have to unmute your mic to ask a question.
Just hello.
Hello.
Hi. Just before you continue,
Yes.
in response to what Doctor was asking, I was wondering, is it possible for us to probably impose a fine on anybody who has pardon? Who has landed in the country and is seen, impose a fine maybe for anybody who has landed in the country and is seen, out of their home in 14 days.
Sorry to interrupt, but in addition to that, I just wanted to ask, I'm seeing where in other countries, they actually have a simple system where they stamp persons who are supposed to be self-quarantined. Like they stamp them on the arm or so to show that this person should be self-quarantined as of this date. So people who see them in public can know that, hey, they need to call somebody. Is that something we can explore as well?
Oh, that sounds good.
All right, now we have a lot of people waiting to ask questions, right? It can't be a free-for-all. So Suzanne, your hand is up next. If you want to ask a question, please unmute your mic. Go ahead, Suzanne, please. Suzanne might not ask her. All right, Mindy Fitzhenley. Sorry, Suzanne, do you want to ask a question? Go ahead, I think we can hear you now. All right, Mindy Fitzhenley.
Yes, I'm here.
Ask your question, please.
Hi, afternoon. I know there was an issue in terms of getting supplies to the private physicians and their offices. This was something that we had previously discussed at other meetings. The permanent secretary said that he was going to look into the issue in terms of being able to help to supply or provide some of these stock for the private offices. Has there been an update on that?
Thanks, Dr. Fitzhenley. Is there an answer to that from the panel or ministry official?
I'm Dr. Bisesa McKenzie here again. I cannot give you an update on that, but I would just want to remind general practitioners that the usual stocks that you have in place in terms of your surgical mask, your gloves, and your gowns that you would have in terms of for use for infection prevention and control are the same items, and your cleaning items in terms of your hand sanitizers, your 70% alcohol, and your bleach for sanitizing. These are the usual items that we would expect you to be using. As Professor Figueroa has mentioned, we would want you to be referring persons who you have as suspected cases for testing to be done. We fully realize that there is a shortage and you would not have been stocking items such as N95 mask in your offices. And so where it is that you need to have those tests need to be done, then it should be referred in so that we can sort out that patient for you.
All right, thank you, CMO. Dr. Jarrett, Carlette Jarrett, please unmute your mic and ask your question. Dr. Carlette Jarrett.
Yes, hi, afternoon, everyone.
Good afternoon.
Hi, I have two questions. I work in public health and primary care. Two concerns. So with the projection of patients that we expect to have to be in, everybody hearing me?
Oh, go ahead. Go ask your question. Go ahead.
All right. With the patients,
you want some salad with this?
Sorry, Sophia, can you mute your mic? Mute it for a second. Dr. Jarrett, go ahead and ask your question. We're hearing you.
Yes, the number of patients that are projected to become infected with COVID-19, do we have or are we in the process of getting more PPEs just to make sure that we are fully equipped? And if not, what would be plan B? So that's one. The second thing, at my health center, I do not have any hand sanitizer. And I heard Minister Nigel Clark saying something about importing raw materials to make hand sanitizer. I don't know if this is true, or if there are any plans to source or have a pharmaceutical company make some hand sanitizer. Any answers to these questions, please?
All right, can anybody respond to that?
In regards to the hand sanitizer issue, a hand sanitizer is primarily based on alcohol, and although alcohol by itself without any of the emollients that are usually added to the sanitizer is a little harsher on the skin, you can actually just put alcohol or white overproof rum in a bottle and spray your hands and then use lotion afterwards. So that's, you know.
Kathy, is there any comment on the strength of alcohol? Because I gather it can't be too strong, you know?
Well, it should be between 62 and 70%. We don't easily get alcohol above 70% except medical grade, and that is not used except for, say, cytology and so on, or in pharmacies to dilute to make other products. So that would be very difficult to obtain. You wouldn't get that commercially as an average person. And I think there are some plans in collaboration with Ray and Nephew, perhaps, to possibly help with the sanitizer issue in terms of local production. But I think that is being discussed possibly with Ministry of Health, and that's something that Ministry will have to determine how that is utilized and addressed.
Okay, thanks. Tino, you have your hand up next. Tino? Does Tina have a question?
Sorry, the second part, the first part of my question in terms of the PPE, that wasn't answered.
Beg your pardon.
Yes, Dr. Bistesa McKenzie here again. In terms of the PPEs, that I am very sorry to hear that you're working in a health center that you don't have hand sanitizer. That is really not acceptable. And that is something that we don't expect persons to be saying at this time, because we expect that the stocks that are available would be deployed, because we are not aware that there is a shortage. So there may just be a procurement issue in terms of getting it to your health center, but we do have stocks in the island for the health sector in terms of the public health facilities. In terms of the personal protective equipment, we have ordered and we do have in stores. The National Health Fund has taken over a large part of the procurement for us. They have quite a bit of supply in stores presently, and they have also orders that are projected to arrive. So we have based our projections initially, certainly on the numbers that we project, but we have been procuring outside of that in order to get as much as we can, especially at this time when we know that globally certain things are going to go into shortage.
Thanks, CMO. Tino?
Yes, thank you. And I want to say thanks to Ministry of Health and everyone. I mean, really and truly big up. I wanted to just ask, as it relates to the Sentinel sites, I can't remember, are there some private Sentinel sites? And if not, or if we do, we could possibly even use, maybe set up those sites initially with that go to, I think I got the name wrong, what Dr. Michelle Roof was talking about, so that they can, you know, sort of feed into the cases. And also I wanted to say, as it relates to contact tracing, I am used to contact tracing as it relates to HIV, and one thing already is commonality, as Dr. Catherine Pate said, you know, the stigma. So what we have to do is be very creative in when we are seeing possible patients or any patients to get some information before even the diagnosis, because once you say the diagnosis, that's the shutting up of the information for the contacts and so on. So for example, somebody brought a little old lady. Yes, you usually have your next of kin, but she may be the caregiver, and if she here, you know, that's the last you might get her. Thank you.
Thank you, Tino. Any comments from the panel for Tino? If not, we're going to go on to Bent. Bent? All right, can we go? Bent, you're going to ask something? All right, Paul?
Yes, yes, I'm going to ask something.
Please go ahead.
I would like to commend you on a good conference. I'm clearer now than I was the last conference last week. And yes, we do see people with asthma, hypertension. If you have seen a person within the last 3 months and they just want a renewal of their prescription, then they don't have to come in. But we used to see a lot of other things, DVTs. I saw 2 multiple myeloma since the year started, so before COVID came. And now it's just COVID, and everybody's scared, including myself, although I'm less scared now. Right? What I want to know is, what is our St. Catherine point where we call in to say we have somebody who is suspect?
All right, so we want to know who the contact person in St. Catherine is. We have that number on.
Right, we had sent it out last week. We'll send it out again to the team leads, the medical officer of health, so that add on the cell numbers for the health, the medical officer of health plus their office numbers. So
All right, I'm going to go on to the next speaker, but before we leave the forum, could we just read out the St. Catherine one for Tina's benefit, since she's here? Paul, did you have a question?
Yes, a number of questions. Dr. Figueroa didn't speak fully to how we are going to revise the testing procedure in terms of who we test, especially in terms of so-called asymptomatic patients. The United States, New York has 10,000 people positive. That's because they have tested 45,000 people. When are we going to expand our testing procedures to take in the umbrella so that we can have a definite idea of the extent of the problem? Second question, our elderly medical staff, doctors 59, 60, who have comorbid problems, what are we advising them, especially if they work in hospitals or centers where they have patients who are positive?
Okay, can we get a response to those questions?
Okay, with respect to the elderly, I think we do need to be sensitive to elderly health providers. And if they have a reservation looking after cases who are confirmed and it is feasible to rotate them elsewhere and have a younger person do it, I think that's reasonable, so that we take that into account. With respect to testing, I have not seen anything coming out of New York that suggests, I've just not reviewed the data, that suggests anything different to what the WHO has found in China, where it is very clear that asymptomatic persons play a very minor role in transmission. It is persons with symptoms, and those who have the more severe symptoms are more infective. So the testing must focus on symptomatic persons, bearing in mind that even when you have symptoms, the current test that is being used is usually negative until day 3 to day 5. The testing, I'm in dialogue with the ministry in relation to us unfolding further testing, and I think that Dr. Webster-Carr already pointed out that she was proposing some testing of, for instance, already wider SARA patients, those with pneumonia, they're already doing door-to-door, and where people in affected communities and where persons have symptoms, swabs are taken and they're tested. Over to Karen.
What about testing people who have been in intimate contact with people who are positive, whether those people are positive or not?
Absolutely. If they've had intimate contact with a confirmed case, as soon as they develop symptoms, not before they develop symptoms, because you can be in contact with a confirmed case and you may not become infected. And if you test too early, then you're going to get a negative test. So you wait until you quarantine, and then if they develop symptoms and they've been in close contact, yes, then you test when they develop the symptoms.
Thanks, Prof. I have a question. I'm going to be 52 next week. Am I elderly or young elderly or older youth?
No, man.
Galaxy S10.
Middle age. I am bordering on elderly. You're still in the younger end of adult.
Galaxy S10. Galaxy S10. Galaxy S10. Or Dr. Shireen Sterling. Dr. Shireen Sterling. Shireen, you have your hand up. Go ahead, please.
Hi, good evening, everyone. Good evening, Minister and CMO. Blessed evening to everyone. So I have question, more than one, but I'll try to summarize. So in terms of airway, and then one in terms of testing. So in terms of the respiratory transmission, which I didn't truly hear Prof. Figure say no. He just said it's primarily contact-based, right? And also in WHO, they're saying primarily contact-based. Even with the conferences they've had, nobody has truly said no in terms of airborne. So even though there's a family spread, how is it that they've truly deciphered that, okay, it was a family spread by contact and not any contribution in terms of airborne, because it's a virus and it primarily affects the lungs. So that's my first question in terms of, hello, Tina? Right, so that's my first question in terms of the airborne spread, because, you know, when you're going to banks and all these other places, you know, people, even though you said a certain amount of distancing, not everybody is employing that, especially if you're in a space that you can't really control. You know, and minorities still can spread to somebody who's elderly or whatever, right? The second question is in terms of when you get a negative test, so that somebody symptomatic or not, you know, we're in, well, you guys said symptomatic. So symptomatic people come with symptoms and you test, but you get a negative. Keeping in mind that viruses, you know, you have a window period. How many of these do you actually test again before you confirm to say, okay, they are definite negative and we're releasing them? Do you have a system where you actually test them again? You know, like how with other viruses that you would repeat a test before you confirm. And then the last part of the question is, what's the sensitivity and specificity of the test? Thanks.
Okay.
Good question. Can we get a response?
Point about negative testing, because if you do have a person who has symptoms and they test negative and you assess that it is fairly early in the course of their illness, you should repeat another test, a second test, if they remain ill. And you may maintain them in quarantine and monitor them if you feel that they've really had close contact with a confirmed case. It would not be wise just to release them at that point, but you would monitor them to see if they get over their symptoms, but you may consider a second test. Now, PCR testing is very sensitive, extremely sensitive. So it is because you may be testing someone a little too early in the course of the illness why it is negative. Your point about airborne diseases, you do have to consider it and be alert, but you know, there are very few airborne. TB, Legionnaires, perhaps. Now, in China, they've actually analyzed how health providers have become infected because they're interacting with confirmed cases. And it is there that they have found by investigating these cases that a significant number of them actually became infected through contact at home or in a household contact. So it is a judgment call. We are very careful about being absolute in these matters. It's a new infection, but it is clear how most people become infected and how transmission usually takes place. That is why we don't speak in absolute terms.
Prof. Figueroa, the initial guidelines were suggesting that the samples taken of secretions from the lower respiratory tract were what was recommended, and that the swabs of the nasopharynx would give you a lesser yield. Is there any update on that?
I have not seen an update on that, but I have seen a study where even early in the development of symptoms, they sometimes grow the virus. They're able to isolate the virus from the upper respiratory tract as well as the lower respiratory tract. But the thing is that despite that, they may not get a positive PCR test, because remember, someone may be developing symptoms, the virus is multiplying, but it may not reach the critical threshold for transmission, even when they grow it. So I think they've seen enough cases for us to have a fairly good idea where to focus our efforts. And it's so important to optimize your efforts.
Okay.
Mr.
All right,
Manning,
Rory? Yes?
sorry, can
Rory?
I just say back something to Dr. Figueroa relating to what I was
Please.
asking before?
Yeah,
Thank
man,
you
go ahead.
so much. You did a lot in terms of, but in terms of the parts where you're positive. Okay, say from what the other doctor said before, in terms of US, you have positive people. I know we don't have the resources to really test wide scale. We have to target it. But say, for example, somebody is positive, right? And we do not test them. And then they go around quarantined and then come in contact with somebody who is probably comorbid, illnesses and stuff. How are we prepared to really contain the minority of people who are positive but not symptomatic, but we fail to pick them up because we're not enlarging our testing scale? Because these positives who are not symptomatic can make somebody else sick.
Yes, this is a very important point, because we've had hundreds of Jamaicans returning to Jamaica from countries where there's transmission taking place. We've had hundreds, if not thousands, of tourists coming from into Jamaica. So I would be surprised if there are not individuals out there who we have not yet identified. And this is one reason for us to expand our testing, but we have to do it in a targeted way. What Dr. Webster already said, she looked at the SARI surveillance. We're not seeing an increase in that. We're not seeing an increase in the influenza-like illness, the general surveillance that we're seeing. But already she's organizing to test. Some of the SARI people have been tested already. These are people with severe symptoms. All of them have been negative. We want to test all of them now, right? In my view. And we want to test some of the influenza-like symptoms. We want to test those in communities where there's transmission, going door to door and they have symptoms. We want to test them. So this is targeted testing. Targeted testing. And we have a couple of ideas where we can do targeting testing. So we may pick up individuals who have not yet come to our attention. Because if the earlier we pick them up and then do aggressive contact tracing, it means we have a better chance of controlling the outbreak. But there been no countries that have been able to control it to the point where you do not get many cases. So we need to prepare to receive many cases. We can't assume that the numbers we are seeing now are not going to multiply and multiply rapidly.
Thanks, Prof. Shireen, you're good? I need to go on to the next person, Rory. Rory? Go ahead, Rory. Rory, do you have a question? If so, go ahead now, please. All right, technical issues. Kevin Whiteley. Kevin Whiteley.
Hi, good evening, everyone. This is just a concern that I had, noting same that occurred in the last meeting, read the helplines that were offered to the public. So the case is, I was alerted of someone who came into close contact with somebody who was on one of those JetBlue flights that was in the press release. So his fiance was on the same flight as the person that came in from, I think it was New York or somewhere like that, and they passed on Mandeville. He was concerned because she went back and she started to develop symptoms. So I told him, you need to self-quarantine yourself, and passed on the numbers to him to phone the numbers. So the concern is that when he called, they said that they will call him back because they're not certain of the process. Now, I know the last form I had like that, someone had a similar issue and said it would be sorted out. So I was surprised that the response was they're uncertain of the process to follow in his case. So, I wanted an update on this said issue, because I mean, if persons are calling into the helpline and they're met with uncertainties, it can affect the quarantine process itself.
All right, I just want to respond to that. We have been getting, Dr. Manning, are you hearing me?
Yes, I'm hearing you, Simon.
Right. Yes, we have been getting these complaints, and we take note of them. We're going to have to review some of the answers that are being given and the referral protocol in terms of what cases to refer and how it is that we deal with the referred cases. We certainly have a lot of tightening up to do where this is concerned, and we are working on that. So I assure persons out there that we note your concerns and we are moving to tighten up this process.
Thanks, Yamo. Nico Antoine? Nico Antoine? Nico?
I'm here.
Go ahead,
I
please.
wanted to thank you all for this presentation. It's timely and necessary. My question will go to Professor Figueroa, actually. I wanted to ask about those patients that were found in Southeast Asia who were actually thought to be cured, healed from their COVID-19 symptoms, who after discharge were found to have positive tests. I believe that was the reason why the opposition, the former opposition spokesman on health had asked about whether we should be doing self-quarantining for 21 days, even 28 days instead of the 14, because there are persons who seem to remain positive for a prolonged period. What is the World Health Organization saying about that?
Okay, this is a good point. My understanding is that there were some persons. Yes, thanks for that question. My understanding is that there were some persons who, having recovered, appeared to have relapsed. And when they relapsed, they may have tested positive. So we do need to be alert, because it seems as if they were only discharged after they had got 2 PCR negatives. So the WHO has not changed its guideline in relation to when you release patients. But I think we do need to be alert and perhaps advise them that they maintain some degree of physical distancing and caution, at least for a couple of weeks. It's just like how we have found out with things like Ebola. I think there's a person who's actually transmitted it sexually nearly a year after he was infected. So, but these seem to be the exceptions rather than the rule. And it does show you that you have to have ongoing surveillance. And if a person who is being discharged does need to be advised, if you notice you're developing any symptoms or you're concerned at all, or if one of your contacts develops anything, get in touch with us right away. Over.
Thank you, Prof.
Thanks, Prof. Dr. TRR. And I'm reminding those who have asked their questions, please unraise your hand so the others will come up on the queue. Dr. TRR.
Hi, good afternoon. I just wanted to find out, how do we approach the issue that with all this fear and concern about COVID, that our patients with non-communicable diseases are shying away from the doctor? Because if that's not addressed, and I don't know how we're going to address it, we're going to have another problem of Herculean magnitude when we start to have patients presenting with strokes and heart attacks and renal failure, because we are all concentrating on COVID and we can't get the message out that, look, we're still open to see other patients, because I think that's the concern. I'm hearing persons are locking shop. We still have other patients to see. So that's another concern that I think we really need to address. Else we might be in real problems.
Thanks,
Andrew, can I just make a comment here before CMO and the Ministry of Health? So wearing my other hat as a WONCO representative, which is the World Health and Family Physician. Prior to this call, we had a Zoom call as well. And I may wish to share some strategies that other primary care facilities are doing. And so basically what they've done is really to divide their days into two. And they encourage their clients or their constituents, if it is that you have your regular problem, your chronic non-communicable disease, you come in the morning, so between say 8 or 12. And if it is that you have fever, cough, or any respiratory symptoms, you come in the evening. And the reason for that, they say, is that they spend the evening doing a full wash down of the place. So in the morning, the facility is spick and span, and so your chronic disease can be attended to. And then there's a break, and then you see your respiratory symptoms. And that they've been using that in several communities and jurisdictions to try and ensure that individuals with other illnesses are attended to whilst we still have some attention on COVID.
CMO, you wish to comment?
Right. Yes, I would want to comment on this. Yes, it is very, very concerning that persons are in fact closing their offices. I think at this time, just as in our public clinics, that we have to look at how it is that we can find alternative ways to reach our patients. I know that there is no financial reward from sitting down and calling all your patients and writing their prescriptions in order for them to continue to get their medications. But as I appreciate what Professor Reid mentioned about scheduling your time in terms of seeing your chronic disease patients at a certain time. Maybe it is that what you could do is have a telephone interview with the persons before they come in to ascertain whether or not they have any other problems. So maybe it is in making your scheduling, you could have your front desk person call your persons that you have appointments for, just do a preliminary check, who is it that is having any kind of respiratory illness. And the persons who are not having the respiratory illnesses, you arrange for them to come in and have their visit. While for the others, as Prof. Reid said, you could arrange another time, ensuring that you have everything in place to see them. So I think we really have to look at how it is that we can find creative ways to ensure that the patients are seen, and as well to keep our businesses open.
Thanks, CMO. Dr. Fire Tablet. Dr. Fire Tablet. Fire Tablet. All right, Dr. Brown Morgan, Anna Brown Morgan. Do you have a question? Dr. Anna Brown Morgan.
Hello,
Right.
hello, can you hear me?
Hi, yes, go ahead, Doc.
Dr. Fire Tablet, I'm sorry, I just couldn't get the page for the microphone, I'm so sorry. I just have a couple of quick questions. This is Dr. Brown, Catherine Brown. Will there be any, can you hear me?
Yes, go ahead, Doc. Ask your question, go ahead.
Will there be any, this is probably budgetary, but will there be any sort of financial backative, if you wish to call it, be eventually made available to private practitioners who are experiencing fallout of income? I know that maybe more banks and so on have been told to stay mortgages and certain debts, but at the end of the day, some persons still have ongoing expenses, rentals. Landlords are not necessarily going to wait. So I'm interested in the financial help in the future, or maybe in the very near future. That's one question. And the other thing I just wanted to say, in addition to the scheduling of patients, what I've seen at one health center is that they actually have a tent outside and a sign saying any respiratory symptom at all must be questioned at this tent, and a decision made at that very point, whether the patient has to be seen inside or needs to be picked up by Ministry of Health to go because they're in an acute state, or can be sent home with advice on take-home, over-the-counter medications, and so they never get inside the clinic. In other words, all respiratories never get through the front door unless it is deemed absolutely necessary, I guess, in certain cases. So that's just a thing I've seen at another health center. So my question is about the financial backative.
All right. Can anybody speak to the financial backative? The minister is there. I don't know if we can put him on the line, but I'm sure it's something that would have to be considered, but I don't know who would be able to speak to that at this point.
All right, I'm sorry, it's such a hard question, but I see the financial difficulty in the future, which is why I raised it.
Definitely.
I see it coming. Just a quick comment to make is that garbage disposal, which no one has really talked about, needs to be absolutely proper. I passed a health center the other day and I saw the gowns and the masks blowing in the breeze in the garbage. I don't know how this virus is going to behave, if it's going to stay long or short on substances such as gowns and masks and be aerosolized, but I think we need to make sure our garbage disposal is proper.
Okay, point taken, Doc. Dr. Brown Morgan?
Yes, can you hear me now?
Yes, I can hear you now.
Right, well, good evening, everyone, Minister and doctors and colleagues. Just a couple of things listening in. Prof Figueroa has spoken about, or is it Prof or someone else, Dr. Webster Carr, this 3-foot rule and 15 minutes in their presence as a part in the, is it in the patient's presence? Is this a diagnosis suspecting the doctor as one of the new groups that you're considering as a suspect for COVID? And is it that we should sit now 6 feet away from our patients and make sure that the ACs are off once you've seen someone with cold and cough and so forth? Because the 3-foot, 15 minutes, many of us do see these patients for more than 15 minutes. So that's, and that's 3 foot is about the distance between the desk and where you sit and the patient at work. The other question quickly is how many corona positive healthcare workers do we have at this time? Another quick thing, somebody was talking about not having hand sanitizer. Please remember that I think it was pointed out before that soap and water for 30 seconds is pretty good. It's not good for the people coming through the door, but soap and water does work. And for Prof. Figueroa, the testing of not testing patients who come into contact with other positives and don't develop symptoms. Should it be considered any at all that these people, when they're adequate tests, should be tested at about 7 days or not to determine whether they actually do have the disorder but no symptoms? And so that we can determine what sort of spread we're getting from patients with no symptoms at all. And from last week, prescriptions, pharmacies are still requesting that even when you call in the prescription, you have to at some point send in the written prescription, otherwise they won't use the health card. And that's when they trust you otherwise the patient has to pay cash. Is there any way around that even for the time being? Lastly, there's a shortage of alcohol for the private doctors. I haven't been able to, I've 1/2 bottle of the gallon, 1/2 gallon, haven't been able to get anywhere in 2 weeks. Thank you. So number of things go around. Thank you.
All right. Can we respond to those? CMO, I don't know if you want to jump in and address the question of the healthcare workers being positive or not.
Oh, okay. Yes, Dr. Manning, thank you. So I would just want to reassure persons that we do not have at present have any healthcare worker that is positive for COVID-19.
Okay, thanks, CMO. The other parts of her question, she had 3 or 4. Prof, would you be able to address I think she mentioned the 3 foot 15 minute. I think that was in your presentation.
Right, it was in mine, and this is just out of WHO. On the 20th, dated the 20th, so it's 2 days old out of WHO. I believe it's based on their experience. And so they have given greater guidance in how to categorize the contact. So it's face-to-face contact with a probable or confirmed case within 1 meter and for more than 15 minutes. So it's describing the risk and your risk profile. So this is what has just come out from WHO based on the experience so far with COVID-19.
And if I could add, remember, in China, the reproductive number, that is the number of persons, if you're confirmed positive and you come in contact with people, on average, in the early part of the epidemic, 2.5 persons with whom you became in close contact became infected. But most of these cases came in contact with many more than 2.5 persons. So they may have come in contact with 10 persons and only 2 or 3 became infected. That is why it is better to limit testing. You would quarantine all those close contacts, and if they don't develop any symptoms in 14 days, then you're pretty sure that those persons have not become infected. And if they do develop symptoms, then you test. But you don't test asymptomatics.
Exposure don't mean infection. Just to say exposure don't mean infection, right? I don't think we have the natural history for that, but like for TB, only about 30% of persons, householders who are exposed become infected.
And that's airborne.
And that is airborne. So you understand what we're saying. Not all exposed are going to be infected.
Thanks much. Prof. Bailey, Alvaston Bailey. Prof. Bailey.
Okay, thank you very much, President Manning. I must congratulate you and your team for preparing this excellent interactive broadcast. I just have one or two questions. I would like to address this question to Professor Figueroa in terms of physical distancing. With respect to the way we manage patients, we oftentimes come much closer to them than the 6 feet or 3 feet distancing. Would you recommend that we regard all patients as provisionally infectious and use universal precaution techniques in order to prevent ourselves from becoming infected? Would you recommend that all general practitioners use personal protective equipment for all patients? That's the first question. The next question I'd like to ask is, how do we deal with physicians who have been exposed to the COVID-19 patients? Do we isolate them? Do we quarantine them? And what becomes of their family after they've been exposed to these patients? The third question I'd like to ask is with respect to health insurance coverage of persons who have been exposed to the virus. Is the government considering establishing an insurance package for physicians who might lose their lives on the job?
Okay. While we're waiting for a response, Prof. Marvin, Reid, you're recording this, I believe. Some of the questions we haven't really been able to answer, but it would be a good opportunity to view the recordings, document them, and see if we can find answers. Because even though some of these can't be answered now, they're going to be relevant moving forward. Go ahead, Prof. Figueroa.
Yeah, there are 3 questions there. I can take the first. I don't think it's necessary to use PPE for all patients. I have not instituted that personally in my office. I use my discretion in relation to the patients who are coming in. However, we do have a protocol that I suggested in my slides for anybody who comes in who appears to have a respiratory tract infection, where you give them a mask, you can put on a mask yourself, and you try to, you can also, for all patients, you do need to be careful, but you can interview them without sitting directly in front of them. Most of us are usually sitting slightly to the side, and you can ease your chair back a little further, and you can assess pretty quickly whether they have respiratory symptoms or not. So I wouldn't say PPE for all patients. In relation to exposed health providers, if they have a serious exposure, then the question of quarantine does arise. However, there is an incubation period, and those that we are most concerned about would be persons who develop symptoms. Such a person who, if they're exposed to a confirmed case or a probable case, and they're beginning to develop symptoms, yes, I think they should be quarantined immediately. And on day 3 of symptoms or day 4, a test should be taken. But Karen, you want to add anything to that?
Prof, I think you meant they should be isolated when they start developing symptoms.
Isolated. But before they develop symptoms, yeah, isolated, you're correct.
Can I also make a comment?
Go ahead, Doc. Quick
one.
So
just in terms of the healthcare workers, when the appropriate personal protective equipment is used properly, then interacting with the patient in that setting is not considered an exposure unless you breach the safety of your personal protective equipment, which is usually at highest risk during doffing or removal of the personal protective equipment. So when you, as say a healthcare worker in the hospital in accident and emergency room, are going to see a suspected COVID case, and you put on your mask and your glove and your gown and you go and you see the patient, then as long as you put on your protective equipment properly, and when you're taking it off, you do it properly, then you would not be considered exposed from that exposure or contact time with the patient.
Thanks, Doc. Dr. iPhone. Dr. iPhone. And those who have asked questions already, please unraise your hand so the queue will move up. Dr. iPhone.
Hi.
Dr. Nick. Dr.
Hello?
iPhone, go ahead. Go ahead, Doc. You have to unmute
yes.
your mic. Go ahead.
Hello?
Yes,
Hello?
go ahead. All right, Dr. Nick. Nick?
Yes, I'm, hello?
Yes.
You have a question, Doc?
Yes, I'm wondering if there's any recommendation to the public the excess exposure to information by WhatsApp and media that is causing anxiety. Are we at all? Am I the only one concerned about the anxiety as a health issue? And is there a way we probably can give them maybe a recommendation of the amount of time they should be using per day to read about COVID-19? I don't know if I'm the only one who thinks that anxiety is a concern.
Thanks, Doc. Any comment from the panel? Any comment?
I don't know if anybody is there from mental health. Is anybody in the EOC from mental health? Okay, well, I just want to comment that that's an excellent point that you have raised, and thank you for bringing it up. I don't think that we have looked at this. I might be wrong, but it's something that we certainly can ask our health promotion and education branch to look at, to see if there's a recommendation that coming from other sources, international, regional sources, if there are any best practices that it is that we could take on and recommend to the public here. But I just want to say, though, that a lot of doctors are getting information that is not validated information and are also resending it out to several persons. A lot of people have a great deal of respect for the medical profession, and therefore what we send out is taken to be gospel many times. So as healthcare professionals, we have to be very, very careful as to what it is that we are resending. And, you know, sometimes you get something, it's important to go back to the source and say, this is not correct, please stop sending it out. So just in short, we will have a look at what you said in terms of our recommendations. And I would just ask for healthcare providers to be very careful in what it is that they are sending out.
Thank you, CMO. Nick? Nick, do you have a question? Nick?
Hi, good evening.
Yes, go ahead, please.
All right. So first of all, I must say congratulations to the organizers of this meeting. I think you guys are doing a wonderful job, and we need to keep communication and like this going so that, you know, we can all be updated as this.
Go ahead, Nick.
As this evolves.
Please mute your thing. Go ahead, Nick. Sorry.
All right. Also to everybody good evening to everybody who is joining in and to the panel as well. My question is probably can be viewed as a suggestion as well. I know that as time progresses and if this unfolds like we anticipated to, we're going to run out of a lot of our resources, which includes our personal protective equipment. Now, I'm one of the frontline workers. I work in accident and emergency. And I know thus far we have been very tight with the use of oars, understandably so.
So my thing is, there has been a recent ban on plastics here in Jamaica, and some of the information coming from other jurisdictions that had to manage this before it came to us. I don't know how true the information it is, but I've seen where they have resorted to makeshift personal protective equipment. So having seen that, my question / suggestion to the Chief Medical Officer is if her team has engaged our local plastic manufacturers to see how best we can go about resolving or managing the Jamaican situation, where we could utilize plastics of a particular or of an adequate grade in making personal protective equipment for our use here locally. Because we have seen where in other places where these gears are manufactured, they had a problem with their stock and it was quickly depleted. We have to import these items. I think we should look ahead and try to make provisions. If that time come, we are prepared to deal with it. Thank you.
Thank you, Nick. Any response to that from the panel?
Yes, I note the comments. I just think also though that we have to be careful sometimes how it is that we generalize certain things, because anything that is used as a personal protective equipment, I would say outside of the gloves, have to be a little bit breathable. And so, for example, we couldn't use plastic to make masks because we would end up in a bit of a problem there. But I note the point, and certainly it is something that we can discuss in our multi-stakeholder meetings, where we would have the private sector present to see how it is that we can do some amount of using whatever it is that we have here to help to alleviate any shortages that may arise.
All right, thanks. Dr. Seni? Dr. Seni? Dr. Seni? Dr. Seni?
Sorry, I am here. Dr. Manning, yeah, no, I was trying to unmute my system.
Go ahead, please, Doc. Thanks.
Thank you. Yeah, Dr. Manning, CMO, and I don't know if the minister is still there. Our colleagues, good evening, and I'm saying thank you for a very well prepared and played out presentation. I have not many questions, except that the slides that Dr. Figueroa laid out, in reading through a lot of journals and so on, looks like a good resume that I think the doctor should have firsthand in their offices. So I wonder if those points that he presented could be given to the doctors as something that they'll be looking at, like as they do their work, so that there is no variation in what they do, not too much variation. And the point that Tina made regarding privacy for the patients, I think it's a very, very good point. And if you've worked with these patients, like HIV, tuberculosis, and so on, privacy is extremely important to them. And I'm sure that this is going to be the same. So I just commending them for those points.
Thank you, Doc.
Yeah.
Dr. Dewar? Dr. Dewar? Remember, if you've asked a question already, raise your hand so the queue will move along.
Yes, good
Dr.
afternoon, everyone. I know if I'm being heard. Yes, I wasn't sure the issue of the hydroxychloroquine was addressed. I don't know if anybody from the Ministry of Health is still there about the increased prescriptions that the pharmacies are seeing. So we're having a run on these drugs that are needed for many of our patients with lupus and other autoimmune conditions. I'm very concerned about that. And I'm hearing that some
is a question about preventing the run on the medications?
Yes.
Okay. Anybody from Ministry of Health can address that? All right, I'm sure our answer will be.
Right. I think that, you know, early within this week, we will have to look at what kind of direction we are going to be sending out based on an analysis of the material that has been out from several sources. Once a decision has been made, then we would have to put in place the necessary measures to ensure that there is adequate amount of medication for the persons who use these medications in the management of their chronic illnesses. And then also to have a projection whether, if we are to use these medications with COVID, how much patients we would be treating and to be able to cater for this. So we would have to take those things into consideration in terms of making a direction. But I believe that early this week, some recommendations are in already and we just have to review them. And I believe that early this week, we should be sending out at least a preliminary advice in terms of what we think may be a best practice. But any such direction is going to be preceded by a detailed look at the availability of the medications and what it is that they're presently being used for.
Okay, because we're getting reports that some of our colleagues are using them as prophylaxis. It's being used as prophylaxis right now for doctors who are worried about getting COVID.
Okay, thanks, Doc. Point noted. Rio? Rio, do you have a question? Rio?
Yes, I do. Hi, thanks very much. Congratulations for those who have organized the panel. Is the Minister of Health still there?
I am not able to tell. I'm not seeing that screen.
Go ahead and pose your question.
He's there. Yes.
Okay. All right. Well, what I personally observed, the Mandeville Public ICU is in a dreadful state. There are leaking roofs, there's mold, and perhaps it's not a surprise that someone died there that had COVID. I'm not so sure if he died from COVID, but he died there. The space is very cramped, and I don't think it's really built fit for purpose. It was never really built as an ICU in mind. Under the emergency procurement powers, is the minister looking to immediately rebuild, say, a 20-bed ICU at the Mandeville Public Hospital and to expand the operating theaters at the Mandeville Public Hospital to like 8, as well as to accommodate a biomedical space? I recognize that under the PROMAC program, the Mandeville Public Hospital benefited from certain equipment, but the ventilators that were delivered were never fit for purpose. They were made in Italy and Spain, and they actually were placed in the isolation cubicle. It's a very urgent and pressing problem, and I'd just like to know what is being done about the dreadful state of the Mandeville Public ICU HDU. Thank you.
Before the minister jumps in, I work at Mandeville, and I can say that Mandeville doesn't have an ICU, and I can say with 99% certainty that the patient who passed away didn't pass away there. Minister, do you wish to make any comment, or you?
I just say defer to you, Chairman.
All right.
Seriously though, I understand the concerns. We have a program that is looking at all hospitals across the country It's not an emergency build out. I mean, the emergency response right now is to isolate wards for possible treatment of persons with COVID who have severe respiratory ailment. And that is going on as we speak, as well as securing equipment, ventilators, and so on to ensure that those persons get the type of attention, as well as securing personal protective gear for our frontline staff. So
could I say something, Minister? I'm not being rude to.
Yeah, go ahead, Minister. You're asked a question, and we want to give you a chance to.
No, I'm just adding the issue of the issues or the troubles. Let's say of the Cornwall, the Cornwall Regional Hospital troubles.
Right. Okay. So can I
Push.
respond?
Well, let me just make sure that.
Sorry, I'm intervening here and overriding you. Could you just allow the minister to answer your question, please? And then you can ask another question.
All right, sure, certainly.
So that's where the focus is. What they needed to see of the response on COVID-19. Beyond that, though, there are some plans for some upgrading of a number of hospitals across the country. I'm not sure it's that relevant now, given what we're discussing. But I'll be happy at some point to outline those plans, which I unveiled in my sectoral last year, which we have resources for, and architectural work is now being done. That, by the way, includes Cornwall Regional Hospital. All right.
But in terms of what's happening with Cornwall Regional Hospital, it's certainly not functioning as it ought. And right now, Mandeville Public Hospital is like the most central place. Patients from Westmoreland, from Clarendon, Lower Trelawney, St. Anne, and actually, even though it's not officially an ICU, it practically functions as an ICU because patients are regularly ventilated in the Mandeville Public Hospital. Dr. Manning, you'd recall advising me to ventilate a patient of mine at Mandeville Public Hospital. So my question is very burning in light of the fact that this COVID disease results in a high incidence of ventilation dependence. And so I'm asking again, this is an emergency procurement issue. The lack of ICU spaces in the central part of the country. Peter Bunting,
All right, sorry, there are a lot of concerns there, but we're going to focus on COVID-19 today. Dr. Foster.
Right. It is
Dr.
COVID-19.
I understand. Give other people a chance. Dr. Foster, go ahead, please.
Hi, good evening, everyone. One of my questions Dr. Dwar had already raised and CMO had answered. I have just one other question, but before I do, I just wanted to commend you and your team, CMO, everyone there, and everyone who's not present, the minister, for a job well done. I mean, this virus is new, and with the little knowledge you know and the resources you have, you're doing a very good job. So I commend you all. Thanks for your sacrifices and thanks for your very hard work. What about, my question is with regards to the health workers who are not in the elderly bracket, but who have underlying medical conditions, particularly respiratory, who would put them at an increased risk. Like myself, I'm asthmatic. Can any special considerations be given to us in terms of where we work at work and what can be done?
All right, can the panel address that?
So in terms of whether patients or physicians with comorbid conditions like asthma, underlying lung problems, cardiovascular diseases, immunocompromised states of certain kinds, like severe cancers and so on, then those do present an increased risk. And ideally, people in that position should not be frontline staff and should be limiting their exposure to any potential contact or case. So that may mean for some institutions redistribution of staff and giving duties that don't require direct patient contact to people who are more at risk so that they are not put at risk unnecessarily.
Thank you.
Dr. Raquel Lowe-Jones, you have a question? Dr. Raquel Lowe-Jones.
Pleasant afternoon, panelists and Minister of Health. I just had a question in relation to the renal services in the country. I am a nephrologist at the Mandeville Regional Hospital, and we have put in place certain infection control procedures. But as Dr. Pate Robinson had mentioned about patients with comorbid diseases, kidney diseases are one of those that have a very high risk of patients developing COVID-19 infections. And most of the renal and dialysis units in the country are very close-knit. Spacing is an issue. So in terms of social distancing, it may be an issue. I'd like to know if a dialysis patient were to become positive, does the ministry have places where we can isolate these patients for hemodialysis? As I understand, I hear that St. Joseph's dialysis unit is closed, and I'm wondering if that could be a possible area to dialyze COVID-19 patients. Thank you.
CMO, can you answer that one?
I'm sorry, I missed that. It was about the dialysis person. Where were they asking if the persons could be placed?
St. Joseph's Dialysis
Hospital.
Okay. Yes. I think that one cannot absolutely rule out any facility at this time. But my main concern where St. Joseph's is concerned is that we don't have a full clinical team in place there. And that becomes an issue when you're going to have a person with comorbid illnesses who now have COVID. To manage those persons in that kind of setting would not be my immediate go-to. So we have to consider it some more, and certainly as time goes by, and if we do get an increase in the number of patients, we certainly will have to utilize whatever facilities we have as the demand increases and we respond to that demand. But at the present time, we do have to consider the lack of a full clinical team in place at the St. Joseph's Hospital when it comes to the management of critically ill persons.
Thanks, CMO. Dr. Lowe-Jones, earlier in a discussion with you, you also pointed out that dialysis patients may have a high false negative rate for certain investigations. You wish to comment on that?
Correct. That is correct. So, especially hemodialysis patients, we have found in the literature in the nephrology world that these patients have a higher risk of false negatives. So if they are tested and are initially negative, the guidelines or the suggestions, the early suggestions for COVID disease and renal disease is retesting 48 hours afterwards. Now I understand that the supplies the COVID-19, and I'm speaking specifically to the reverse transcriptase PCR testing, which has a high false negative, not only in renal patients, dialysis patients, but critically ill. So I just hope that the ministry is aware of these patients, that if they are positive or suspected, or they have a false negative, they have a negative test initially, they need to be retested 48 hours after.
Thanks, Doc. Dr. Lewis?
We note that.
Sorry, CMO, you want to jump in? Go ahead.
Right, I'm just saying that we take note of that comment.
Okay, thanks. Dr. Lewis?
Yes, good afternoon. Hello, good afternoon.
We're hearing you, Doc. Good afternoon.
Yes,
I am not sure if there is sufficient information about this out as yet. It may be too early, but is there any data regarding persons becoming reinfected with COVID-19?
Prof?
Yeah, the WHO report said that when they did look at the serology, there was quite a robust immune response among patients. Now, obviously, they have no idea how long that immune response will last. But I think the view is that in the short term, it is unlikely that someone would become reinfected. But we don't know how long the immunity would last.
Okay, thank you.
Thank you, Doc. Sharika? 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 All right, can we go on to Donald Gordon then? Dr. Gordon? Hi, Doc. Go ahead and ask your question, please. Not hearing you, Donald. All right, we're having a marathon here this evening. Prof. Reid, any advice on the cutoff time?
Yeah, I think we have done pretty well in terms of timing, and we should be about thinking of wrapping up now because as you know, whilst a lot of us are at home, the ministry team is still at work, and they do have other things that they have to prepare for.
May I suggest the persons in the queue type quickly your question to the chat group, because it is being recorded and perhaps it could be addressed and answers circulated at another point. I'm going to ask one last question, and that's Felicia Bonner Reid. Felicia Bonner Reid. Felicia Bonner Reid. No? Okay, Dr. Sterling. Dr. Sterling.
Hi, this is a question for MOH, specifically the minister. Good evening again, everyone. So it's about the airport. I know we're currently closed, but at some point we'll have to reopen, and then you have more possible cases coming in. Currently, somebody came in and they were not asked any question for a very high risk area. So how can we, implement, maybe you guys are not aware of that, but how can you go ahead of, what are the measures you put in place to analyze people coming from these high risk areas, and how can we go about, prepping to prevent that happening again?
All right, I'd like to respond to that.
Thanks.
Okay. So in our review of what is happening, I have taken note of so many complaints that I have received and other members of the Ministry of Health and Wellness team have received in terms of the vigilance at the airports. So I'll tell you what the procedure is supposed to be. And certainly during this time that the airport is closed, we have to look at how it is that we ensure that once there is any reopening, that these procedures are followed. Now, it may mean that there is a change in the procedure as we go on, but as it is right now, we have issued a script to the airlines for this to be read on all flights coming into Jamaica. This script is to sensitize persons on the plane, if they do not know already, that there is a process of self-quarantine that is required for persons that are being landed that are coming from areas where there is local transmission. Once persons are so sensitized from on the plane, then it is that at the immigration desk, all persons, and the immigration desk is supposed to be updated on a daily basis with that list of countries. Persons at the immigration desk, persons will receive information in the form of a brochure on what home quarantine is about, what is required of them. They will also receive contact information to contact the Ministry of Health in case they should develop any symptoms. Now, the countries that we have specific landing restrictions on, as you know, we have issued landing restrictions on 9 countries, and persons coming in from those countries would further get a quarantine order. That does not include the USA and Canada. So persons coming from USA and Canada would receive at the immigration desk the information on home quarantine and the contact information, and they would have been sensitized on the flights as to what is happening where these are concerned. But persons from the 9 countries, they would be referred to the health desk for them to receive the quarantine order, because we have that already down, that those 9 countries are countries that we have landing restrictions on. So that is the procedure. We may go on to the fact that in terms of landing restrictions, you know, everybody that is coming in, as it is now, everybody that is coming in now are subject to self-quarantine. So it may be in the future that either the number of countries are increased or some countries are taken off. We haven't reached there yet, but these are the procedures that we have in place now in terms of persons receiving information as to what it is that they are supposed to do.
All right, thanks. CMO, since you have the mic, you want to give any closing comments to the group? I'm going to invite also the minister, and then I'm going to say something.
Well, I would just want to say that everybody has a responsibility when it comes to stopping the transmission of this disease. Now, stopping the transmission may not be something that we can achieve, but certainly I think that we have been slowing it down, and we can slow it down to a pace where we are able to deliver care to those persons who require care. When we go into a phase where we have community transmission, then we do expect that the number of cases are going to increase, and our response will change when it comes to all the different strategic areas. But our responsibility as healthcare professionals do not change, because we still have a responsibility towards our patients. And it is how we deliver that responsibility, taken into consideration our own personal needs and our own personal responsibilities to our families and to those around us. I believe that if it is that every single person takes the responsibility serious and pass it on to their patients, what their responsibility is in terms of monitoring their own home situation, offering advice to their neighbors and to the other persons they see and they have some contact with, in terms of what they are to do to stay home if they are sick and to maintain infection prevention and control measures. I believe that we can do well in terms of the management of this outbreak. And I just want to encourage everybody just to take on that responsibility wholeheartedly, so that we can continue to manage this crisis.
Thank you, CMO. Dr. Tufton, do you wish to say anything to the...
Yes, thank you very much, Chairman. Let me just thank you and your organization for helping to support the setting up of this Zoom meeting. I really appreciate what you have done, you and your team, and for your able chairmanship of the proceedings. And to my team here, usual thanks to them, Professor Figueroa, and all others who are here and online. Ladies and gentlemen, I really want to just express my appreciation to all of you, whether you're in the private sector, public, or both, for taking time to engage, to express your concerns, your queries. Hopefully we would have answered, if not all, most of them. But very importantly, to be part of the solution, which we all need in terms of overcoming this particular challenge. I am the least qualified amongst all of us here to speak on medical issues, but certainly from a policy perspective, we understand in government that these are very difficult times and it is going to affect all of us. All of us are going to have to make sacrifices. I've taken note of the concerns and comments around earning capacities and improvement of facilities. You know, we're very resilient as a people. We've overcome many of these types of challenges in the past, and I'm sure we're going to be able to overcome this one. And we will work as we go along to assess the situation as they unfold. I know the Minister of Finance, for example, is speaking next week in the Parliament around a stimulus package to deal with some of the economic issues. So I would urge us to listen, and to the extent that there are areas that you can relate to, or if not, we can have another conversation at another time. In terms of the immediacy of the equipment, protective gear, and so on that's needed, we are on top of it in the sense that we have the resources. We have ordered a number of additional equipment and medicines, and some due to arrive starting this week. In fact, this past week, some ventilators arrived in the island. And so we are managing that process to ensure that you have the supporting equipment to deal with the patients that you may have to encounter. We really need an effort by private and public. And so I want to encourage our private sector players. Last week, I became a bit concerned because there were some discussions around doctors closing their offices. And I hope that a meeting of this kind would have helped to alleviate some of the concerns, and that we may, if we had those concerns, be now confident around playing our part, because we have to work it as a group, as a holistic group. To the extent that you have any other concerns, please feel free to share. There are some lines available and an email, 2 email addresses. I'm sure, if not, we can send that out. 2 lines for doctors, right? So we will try to man those lines to ensure that the concerns that are raised can be dealt with. As the Chief Medical Officer said, and I'm closing off now, we still have a little distance to run. This is not a sprint. Based on the historical evolution of the virus, it is sprinting across the world and within countries, but it's going to take a little time for us to break the back and to be in total control. And some of those measures are not entirely within our control. So it depends on what other countries are doing, what science is doing. So it's difficult to predict with absolute certainty. What is very certain, however, is that we have to be alert and we have to be prepared to adjust as we go along, depending on what the challenges that are presented to us represent. So thanks again. And I will certainly keep in touch with the technocrats here, and by extension, therefore, keep in touch with you. Thank you.
Thank you, Minister. So I'd like to thank everybody involved in putting this on. We've had a marathon today, but as Minister said, this fight against COVID is a marathon. I wish to say 2 things which perhaps haven't been said yet. To my colleagues, my colleague doctors, to fellow members of the MAJ, to all healthcare workers. In this time of crisis, our country needs us. As doctors, we have to stand up to the test. The second thing is this: after this crisis passes, and it will pass, after the dust has settled, history and people will judge us. And I hope that as a group and as individuals, we will be able to say as doctors that we stood up for our country. Thank you.
All right, thank you, Andrew, for that. And I think it's a fitting way to end the meeting. I just wanted to say that at peak, we had roughly about 451 participants, and I thought that was a good showing. What I also think that we perhaps would need to do, Andrew, is create a repository where individuals whose questions yet have not yet been answered, that we can collate them and certainly provide some resources for them to help them effectively carry out their duties and their functions. So again, thank you for accepting the role to chair and thanking the ministry for participating so ably. And ladies and gentlemen, the meeting is recorded. We hope to disseminate the outcome of the meeting to all during the course of this week. And thanks again.
Thank you all.